Great. Good afternoon. I'm truly grateful to the organizers for asking for our presentation to be presented. I'd like to acknowledge the authors, in particular Steve Shaffron and Sergio Borgia. I think doing research should always be fun, and it's always fun working with those guys. Also like to acknowledge the patients who've entrusted us with their data. So, a little bit of background. Elderly patients were seldom treated for hepatitis C in the interferon era due to concerns about the side effect profile of that treatment. Interferon-free DAA therapy has minimal side effects, making treatment feasible for many more patients, including the elderly. And so we are reporting on the demographic and outcome data of our patients in three major clinical settings in patients over 75 years old who are treated for hepatitis C with DAAs at our sites. Now, why 75 years old? Well, a number of reasons. The first is the elderly are identified as a priority population, and we'll talk about more of that in the next couple of hours when the blueprint document is revealed. Two, if you think about the baby boomer cohort that we are all supposed to be screening as healthcare providers, it starts at 1945. And if you do the math, in 2020, a patient born in 1945 will be 75 years old. And thirdly, as I progress in my career and my life, the well-being of the elderly becomes more and more relevant to me. Okay. So the Hep C population is aging. We have very limited clinical trial data in individuals in this age group. There's even less data, limited to one study looking at the use of ribavirin in individuals over 65. And this suggested more side effect profile in people over 65. There's certainly biases involved in both provider and patient interest in pursuing therapy at this age. This population has more comorbidities, more fibrosis, more polypharmacy and potential for drug-drug interactions, potentially gut absorption and metabolism issues that aren't fully studied in the elderly population. And there's financial considerations in the elderly that younger, healthier, working individuals may not face. So there really is a vacuum of knowledge with this particular population that we hope to address. So we looked at all Hep C infected patients greater than 75 years or older at our centers who received interferon-free DAA therapy. And we gathered information on demographics, treatments, and outcomes from our sites in Ottawa, Edmonton, and Brampton. And the fibrosis scores were determined by transient elastography. So the average age was 79 years old. There was a range of 75 to 88, who was our oldest individual. You can see that slightly over half were female, slightly over half were white, but we had a representation of Asians and Blacks as well in our cohort. Most were treatment naive. Most were genotype 1 infected, a little bit more 1Bs compared to 1As. But we had a representation of 2s, 3s, a couple of 4s as well. High proportion had advanced fibrosis. 41% had Frank's cirrhosis, so a FibroScan score of 12.5 kilopascals or more. But you can also see that there was another 13% who had F3 fibrosis. This is a description of the treatment regimens. All of the first-line agents over the last couple of years were used in our population. There were 78 individuals in total. 73 achieved an SVR, so it's a 94% SVR rate, which, as I'm sure everyone would agree, is consistent with what we've seen in clinical trials as well as in real-world cohorts. There were no virologic failures or post-treatment relapses. We had 3 patients who didn't complete therapy, 1 who was lost to follow-up, and one who completed therapy, but we didn't have SVR blood work in that individual. So 13 out of 78 individuals, 17%, received ribavirin-containing therapies, and the doses ranged from 400 up to 1,000 milligrams a day. In non-ribavirin recipients, 64 out of 65 individuals achieved an SVR, and the one who didn't was somebody who stopped because of a sofosbuvir-amiodarone interaction at week 2. In the ribavirin recipients, 9 out of 13 achieved an SVR. Okay. There were 2 deaths, one from end-stage liver disease well on therapy, and one from HCC 6 months after completion of therapy. One discontinued all hep C therapy at week 2, and then one was lost to follow-up, and that was in a ribavirin recipient. The on-treatment nadir hemoglobin in ribavirin recipients was 95 grams per liter. So those healthcare providers will recognize that this is a clinically relevant degree of anemia, and there was a range of as low as 57 and 128. Ribavirin dose was reduced in 3 of 13 cases and discontinued in 2 of 3 of these patients. And 3 received on-treatment red blood cell transfusions. This is the description of the ribavirin recipients. There was 1 post-treatment death. That was the individual who developed HCC. There was 1 on-treatment loss to follow-up. There was 1 individual who interrupted all treatment after 2 weeks and did not achieve an SVR. And then there was 1 on-treatment death who developed end-stage, decompensated liver disease. They already had advanced liver disease at the time, and the rest achieved an SVR. Strengths and limitations to mention. This is actually a relatively large sample size, one of the largest and certainly the best described report of individuals over 75 receiving treatment. And no other report has focused specifically on this older group. So acknowledged selection bias and outcomes of the non-treated. So there's a selection bias for who got treatment, and we obviously aren't considering people who didn't receive any DEA therapy to look at their outcomes. We don't have long-term data on SVR maintenance or liver outcomes, which is very important in this population. We don't have patient-reported outcomes to discuss, and there's no data on the relative amount of oversight or resources required to usher a patient through this treatment, and we think that this would be additional information that would be of value. So what do I think we can conclude from this? Well, I think the safety and the efficacy of ribavirin-free DAA therapy is well demonstrated by our report, and it's similar to younger patient populations. With our small sample size, we can't really suggest one way or another that the addition of ribavirin is of benefit in achieving higher SVRs or detrimental, but we can certainly say that there's a higher degree of side effect concerns with the use of ribavirin. So what I think we can say is that if you think that ribavirin is required in your elderly patient, you better watch that person very carefully because you're going to run into more side effects. And that is all. Again, thank you very much for your attention, and happy to answer questions.
While we're waiting, I was curious about the acceptability in this patient population. Did you have anyone who refused treatment?
So we didn't capture that, this was just the 78 people who agreed to treatment. I can tell you from my own experience, you'll sit down with an individual and you'll talk about the pros and the cons and why it makes sense or why maybe it doesn't make sense. And there are some people that say, you know what, I don't have a lot of fibrosis. You're telling me that it's unlikely I'm going to get sick with this, so I think I'm going to take a pass. a lot of people of that age are on a lot of medications, and they're not keen on adding anything more to their collection of pills, or there's important drug-drug interactions that it would create some issues if you had to modify their meds to address that. Dr. Shaw.
Hi, Curtis.
Hey, how you doing?
Great work. I think it's an important population to know more about. I guess one of the challenges clinically is that often the decision is made not to pursue treatment. So that upstream population from the population you've studied, I think, is also really important to know what happens to people who are not offered or treatment isn't recommended. And I'm just wondering, like, if you can start to tease that out, even in the data that you have. Like, I think it would be interesting to also explore some of the issues common in geriatrics, like polypharmacy, cognitive impairment, whether you could identify the prevalence of that in this population, because I think then you could make the argument that if you can treat patients with those features, so there's, the so-called geriatric giants, and that those should not become exclusionary sort of reasons to exclude patients from treatment altogether, and that would just be another area to explore possibly.
Yeah, so I think we can use some of our CAN-HEP-C data sets to explore this, and I think our group should go back and look at our 75-year-old and older patients who weren't offered therapy. It's important to realize that if you make it to 75 years old and you're non-smoking male, on average you have another 10 years, and if you're female, you have on average another 13 years. So there is a potential, especially if you have more advanced fibrosis, to lose a lot of years due to the complications of Hep C. So with that in mind, I think it makes a lot of sense to at least consider therapy for these individuals. And we need to protect against our own biases. We want to protect people from polypharmacy and toxicity, but there's also potentially a lot of years of life lost by not offering therapy even at this older age.
All right, thanks very much, Dr. Cooper. Sorry, just for the matter of time, we'll just move on to the next presentation. Sorry. All right.